Hashimoto's is real, but the problem is that once people get the label, everyone stops asking better questions. Let's talk about Hashimoto's disease through the Praxis lens. Hashimoto's is one of the most common autoimmune thyroid conditions. In simple terms, the immune system begins targeting the thyroid gland. Over time, the immune attack can damage thyroid tissue and lead to hypothyroidism, low thyroid output, slower metabolism, fatigue, cold intolerance, weight gain, constipation, hair shedding, brain fog, dry skin, low mood, poor recovery, heavy periods, and a body that feels like it's stuck in a low gear. But here's where medicine often gets too simple. Someone has an elevated TSH, maybe low free T4, maybe positive TPO antibodies, maybe positive thyroglobulin antibodies, and then they get the label, Hashimoto's. That diagnosis may be correct, but the diagnosis is not the whole story. That's the Praxis point. A diagnosis names the category. It does not explain the full pattern. Hashimoto's is usually diagnosed by looking at a thyroid function and immune markers. TSH tells us how hard the brain and pituitary are asking the thyroid to work. Free T4 tells us how much thyroid hormone is being produced and available. Free T3 may help us understand the active thyroid hormone side of the conversation. TPO antibodies and thyroglobulin antibodies can suggest autoimmune thyroid involvement. Ultrasound may be used if there's a goiter, nodules, or asymmetry, or some other structural concern. But here's the problem. When someone meets the criteria, too many people stop thinking. They say, you have Hashimoto's. Then everything becomes a thyroid. Fatigue, thyroid. Weight gain, thyroid. Brain fog, thyroid. Hair loss, thyroid. Depression, thyroid. Joint pain, thyroid. But that's not clinical reasoning. That's label-based medicine. Hashimoto's may be part of the pattern, but it may not be the only pattern. And sometimes it may not even be the dominant pattern. That's where feedback loops matter. The thyroid doesn't operate alone. The hypothalamus talks to the pituitary. The pituitary talks to the thyroid. The thyroid releases hormone. That hormone feeds back to the brain and the pituitary. That's the HPT axis: hypothalamus, pituitary, and thyroid. But the thyroid also interacts with the immune system, the gut, the liver, mitochondria, the adrenals, sex hormones, insulin, inflammation, and stress biology. So when someone has Hashimoto's, the question isn't only, what is a TSH? The better question is, what feedback loops are pushing the system out of balance? Let's name a few. Number one, the immune-thyroid loop. Hashimoto's is autoimmune. So the immune system is not just a side note, it's central here. If the immune system is chronically activated, inflamed, dysregulated, or exposed to triggers, the thyroid may stay under pressure. The question then becomes, what and why is the immune system targeting thyroid tissue? What's driving inflammatory tone? What is sustaining immune activation? Number two, the gut immune loop. A large part of immune regulation is connected to the gut. Gut barrier integrity, microbiome balance, food reactions, infections, dysbiosis, constipation, low stomach acid, bile flow, nutrient absorption. All of these can influence immune signaling. This Doesn't mean every Hashimoto's case is caused by the gut, but it does mean the gut belongs in the investigation. Number 3, the stress-thyroid loop. Chronic stress changes the physiology of thyroid function. Stress can affect sleep, cortisol rhythm, blood sugar, inflammation, conversion of T4 to T3, nervous system tone, and immune regulation. A patient may be told that their thyroid is the problem, but the deeper pattern may be your stress system is keeping your thyroid economy suppressed. Number 4, the liver conversion loop. The thyroid gland produces mostly T4, but the body has to convert T4 into T3, the more active thyroid hormone. That conversion happens in multiple tissues, including the liver and the gut. So, if someone has fatty liver patterns, inflammation, poor nutrient status, high stress, calorie restrictions, illness, or metabolic dysfunction, thyroid hormone conversion may not be optimal. The thyroid may not be the only issue. The conversion environment may be the issue here. And number 5, the insulin-thyroid loop. Insulin resistance can create fatigue, weight gain, inflammation, cravings, poor metabolic flexibility, and difficulty losing fat. Those symptoms can look like thyroid symptoms. So, if someone has Hashimoto's and insulin resistance, the thyroid label may not explain the whole clinical picture. A patient may need thyroid support, but also metabolic correction. And number 6, the nutrient-thyroid loop. Thyroid biology depends on nutrients: iodine, selenium, zinc, iron, tyrosine, vitamin D, magnesium, B vitamins, proteins. I'm sure I missed some, but this is where nuance matters. More isn't always better. For example, iodine is essential for thyroid hormone production, but excessive iodine can aggravate autoimmune thyroid pattern problems in certain people. So, the Praxis question isn't what supplement is good for thyroid. The better question is what nutrient bottleneck exists in this patient and what is safe to correct. Number 7, the hormone-thyroid loop. Estrogen, progesterone, cortisol, testosterone, insulin, leptin, and thyroid hormones are not isolated. They communicate. This is why thyroid symptoms may worsen around pregnancy, postpartum, perimenopause, weight gain, chronic stress, or major hormonal transitions. So again, the thyroid may be involved, but the system is larger than the thyroid. Now, let's talk about the problem with diagnosing everybody who meets the criteria. This is where people misunderstand what I mean. I'm not saying do not diagnose Hashimoto's. If someone has thyroid dysfunction, positive antibodies, and a consistent clinical picture, the diagnosis definitely matters. It can guide monitoring, it can guide treatment, it can guide risk awareness. It can explain why thyroid function may decline over time. The problem is not the diagnosis. The problem is reducing the whole person to the diagnosis. Because if every symptom gets blamed on Hashimoto's, we may miss sleep apnea, iron deficiency, B12 deficiency, insulin resistance, fatty liver, depression, medication effects, chronic stress, perimenopause, low protein intake, overtraining, undereating, inflammatory bowel patterns, autoimmune overlap, environmental exposures, infectious history, or another endocrine problem, just to name a few of them. This is why the Praxis lens is different. We do not ask, does this patient have Hashimoto's, and then stop. We ask, what is the pattern? What is the signal? What is the system? The pattern is the story. When did symptoms start? What changed before they started? Was there pregnancy, postpartum, viral illness, major stress, weight gain, calorie restriction, overtraining, medication changes, gut changes, sleep disruption, a new autoimmune diagnosis? The signal is what the body may be communicating. Is TSH rising because the thyroid is failing? Is free T4 low? Is free T3 low because conversion isn't there? Are antibodies showing immune activity? Is fatigue actually from low iron, glucose swings, poor sleep, or inflammation? The system is the bigger network. The immune system, the gut, the liver, metabolism, stress axis, nervous system, mitochondria, hormones, recovery capacity. That's the Praxis model. Pattern, signal, system. Now, where do peptides fit in this? First, peptides are not first-line treatments for Hashimoto's. They do not replace thyroid hormone when thyroid hormone is needed. They do not replace proper labs. They don't replace medical eval. They don't replace ultrasound when it's indicated. They don't replace screening for red flags. But peptides may belong in the conversation around the systems that influence Hashimoto's. For example, thymosin alpha-1. TA1 may be discussed through the immune regulation lens. Hashimoto's is autoimmune. So the question is not boost immunity. The question is immune balance, tolerance, surveillance, overactivation, inflammatory tone. TA1 belongs in a conversation when we're thinking about immune coordination, not randomly stimulating the immune system. Then we have KPV. KPV is interesting because it belongs in the inflammation and gut barrier conversation. If a patient's Hashimoto's pattern includes gut irritation, inflammatory tone, or barrier dysfunction, KPV may be worth discussing as part of a broader gut immune strategy. Not as a thyroid cure, as a potential signal inside the gut immune loop. Then we have BPC 157. BPC 157 is often discussed around tissue repair and gut support. In Hashimoto's conversation, I wouldn't frame it as treating the thyroid. I would frame it as a gut barrier and repair conversation. If the patient has GI symptoms, inflammatory gut patterns, or recovery issues, that may be contributing to immune activation. Then we have one of my favorites, VIP. VIP is a neuroimmune peptide. It sits in the conversation of inflammation, immune signaling, mast cell behavior, gut barrier, and nervous system regulation. For the right patient, especially one with neuroinflammation symptoms, this autonomy-like pattern, mold toxin history, mast cell type symptoms, or chronic inflammatory burden, VIP may be part of advanced clinician-guided discussion. Again, not a casual Hashimoto's peptide, a neuroimmune signal. Then LL37. LL37 is more complex. It is an antimicrobial peptide involved in innate immunity and barrier defense. But because immune activation can be a double-edged sword, LL37 needs caution. And in autoimmune patients, the question is not, can we activate immunity? The question is, will this immune signal help the pattern or make immune reactivity worse? That is why peptide medicine needs systems, not lists. So the Praxis peptide lens for Hashimoto's is this. Do not ask what peptide treats Hashimoto's. Ask which feedback loop is dominant. Immune dysregulation, gut barrier, chronic inflammation, stress physiology, mitochondrial fatigue, metabolic dysfunction, poor recovery, neuroimmune activation. Then ask, is there a peptide signal that fits that loop? And if there is, what is the risk? What is the evidence here? What is the monitoring plan? What would make us stop? That is peptide medicine. It's not hype, not protocols, not Hashimoto's equals this peptide. A final note, Hashimoto's patients are often frustrated because they're told your labs are normal, but they don't feel normal. Sometimes that's because the thyroid treatment isn't optimized. Sometimes it's because the thyroid was never the only problem. That's the message here. Hashimoto's is very real. The immune attack is real. The thyroid dysfunction is real. But the patient is more than just the diagnosis. The thyroid is part of a network. And if we only treat the label, we may miss the loop that keeps the system stuck. That is why Praxis Peptide Institute teaches through pattern, signal, system, evidence, risk, monitoring, and decision. Because the goal isn't to collect diagnoses. The goal is to understand the human being behind the diagnosis.